Milk alkali syndrome and hypercalcemia. Hypercalcemia occurs when entry of the calcium from GI tract and bone exceeds the rate of loss, urine loss, and bone deposition. Should be confirmed with albumin level and preferable ionized calcium. Clinical manifestation include calcium 10.5 to 12, usually asymptomatic. 12 to 14 symptoms may depend on the acuity, and more than 14 usually symptomatic. Could be neurological, psychiatric symptoms, renal, GI, and CVs. Diagnostic approach include first determine whether it's real, next check the PTH level. Step 1. First we need to assess the clinical history, draw the blood test, do physical examination, check medications, repeat calcium, check albumin, intact PTH, elevated calcium in PTH and primary, tertiary, and check urinary calcium or phosphate. Urinary calcium is elevated in 40% and low FHH on primary with concomitant vitamin D deficiency. So then do a calcium clearance, and phosphate is usually elevated in tertiary but low in primary. Check the PTH. If elevated, usually confirms the diagnosis of femoral hypercalcemia of malignancy. However, this assay is often not necessary to diagnose, since most of the patients have clinically apparent malignancy. The production of the PTH intact and calcitriol is usually appropriately suppressed in these patients. Step number 3 is analyze the vitamin D metabolites. Calcidol and calcitriol should be measured if there is no obvious malignancy and neither PTH nor PTH-RP levels are elevated. Elevated calcidol is indicative of vitamin D intoxication due to the ingestion of either vitamin D or calcidol itself. Elevated calcitriol may be induced by direct intake of this metabolite, extrarenal production of granulomatous disease or lymphoma, or increased renal production that can be induced by primary hyperparathyroidism but not by PTH-RP. Look for other causes. Presence of low serum levels of PTH, PTH-RP, and vitamin D metabolites suggest some other sources of hypercalcemia. Absence of malignancy or increased PTH, unsuspected stimulation of bone resorption as with multiple myeloma, thyrotoxicosis, immobilization, Paget's disease, or vitamin A toxicity, and unrecognized calcium intake in the face of the renal insufficiency, as in the milk alkali syndrome, are most likely the candidates. Originally recognized, milk alkali syndrome was recognized in 1920s during the administration of CP regime, consisting of the milk and bicarbonate for the treatment of peptic ulcer. One study found that the milk alkali syndrome accounted for 2% of hospitalized patients with hypercalcemia between 1985 and 1989, as compared with 12% between 1990 and 1993. Calcium in large doses may lead to suppression of parathyroid hormone, which then produces enhanced bicarbonate retention by the kidney. Continuing ingestion of the calcium carbonate and carbonate retention leads to alkalosis, which causes increased calcium reabsorption in the distal collecting system of the kidney. Also, hypercalcemia produces a renal concentrating defect that can be considered from nephrogenic diabetes insipidus. Excessive dietary calcium: 3/4 cup of total cereal, 1 cup of milk is equal to 1300 mg of calcium. Treatment: fluid calcitonin inhibits osteoclast formation. Furosemide inhibits calcium reabsorption in loop of Henle and bisphosphonates.